Hello, and welcome to lecture number 4 in this series on drugs and human behavior. Today we're going to be talking about epidemiology and neurobiology of addiction. So basically we'll be taking a look at a couple of major issues in addiction research, primarily dealing with how people are defined as having addiction problems, how many people have such problems, how many people use and abuse certain drugs, and then we'll also be looking at some of the neurobiology behind addictive processes, particularly looking at what's called the reward pathway. So we'll start with an introduction to the Controlled Substances Act. So this is going to be important for us to discuss throughout the semester where things fall into these different schedules and how they relate to things like research, whether or not they can be used in medicine, or if they've been deemed to have no redeeming qualities whatsoever. We'll then take a look at the prevalence and incidence and impact of drug use and abuse, talk about the neurobiology of addiction and the reward pathway, talk about how one might move from simple drug use or abuse to addiction, talk about the epigenetics of addiction and how drugs might affect our genetics processes, and finally finish up with some proposed pharmacotherapy of substance use disorders. So we'll start with a discussion of the Controlled Substances Act. The CSA was enacted in the late 1960s in a context that is pretty clearly part of our understanding or our story of how drugs came to be known in the United States in particular. So we'll talk a little bit about that, talk about drug schedules, talk a little bit about methylene dioxymethamphetamine, which is ecstasy, which is kind of a cautionary tale on how drug scheduling can actually make some drugs more prone to abuse. And then finally, introduce this public policy debate on rescheduling marijuana, because we're certainly going to be having a major discussion on that later on in the term. So in terms of the history and context of the Controlled Substances Act, this CSA was enacted in 1970. As I'm sure you know, the 1960s saw a dramatic increase in drug use, culminating in what we call the Summer of Love in 1969. Lots of marijuana use, hash use, LSD, mushrooms, lots of the hallucinogenic drugs were part of this whole culture. And the sort of mainstream culture in the United States had a pretty significant reaction to that, and as a result, they saw this as a threat to their well-being, and so the Controlled Substances Act came about in 1970. So, in addition to the fairly large-scale drug use, this coincided with war protests and a pretty massive drug use in the military. Vietnam showed a really high number of veterans coming back with substance abuse problems. And we're going to talk in a little bit about the effects of stress, particularly chronic stress, on propensity for addiction. But you can see somebody that's smoking marijuana out of a shotgun probably has lost a little bit of their ability to think rationally, because that is, for me, a very shocking thing to see. So the DEA, or the Drug Enforcement Agency, was created by an executive order from Richard Nixon in 1973. The Drug Enforcement Agency is tasked with enforcing the Controlled Substances Act and is an important part of our war on drugs. So drugs and other substances that are considered controlled substances are divided into 5 different schedules. These different schedules are supposed to divide drugs up into the most dangerous and the least dangerous of different kinds of controlled substances. Now, not every drug is a controlled substance. Some aren't scheduled at all, so antibiotics, for example. These are substances that are prone to abuse and certainly prone to addiction. So substances are placed in their respective schedules based on whether they have a currently accepted medical use and treatment in the United States, their relative abuse potential, and the likelihood of causing dependence when abused. So these different schedules take into account, or are supposed to take into account, the best science about how accepted medical use, abuse potential, and likelihood of dependence. Of course, being public policy in the United States, a great deal of this has political overtones to it, and so anytime a drug is rescheduled, there is often a pretty significant political debate behind it. So Schedule 1 is the highest classification, so the drug or other substance has a high potential for abuse. The drug or other substance has no currently accepted medical use in treatment in the United States. There is a lack of accepted safety for use of the drug or other substance under medical supervision. Drugs in this schedule include heroin, ecstasy, marijuana, and more recently what are called cannabimimetic agents. These are drugs that mimic the effects of marijuana. So these are things like spice or synthetic marijuanas. So Schedule 1 is the highest classification. There is a lot of controversy, of course, about how things get scheduled. In Schedule 1, heroin's pretty straightforward. Ecstasy, questionable, and we'll certainly talk about why marijuana is in the same schedule as heroin, but cocaine is still in what's called Schedule 2. I want to talk for just a second about cannabimimetic agents, because this is a really interesting addition to the Controlled Substances Act. In 2012, Congress added cannabimimetic agents to Schedule 1. This is the first class of drugs that are defined by which receptor subtype they influence. So it's not just marijuana, it is any substance that is a cannabinoid receptor type 1 agonist, as demonstrated by binding studies and functional assays with any of the following structural classes. And so they go on to list those classes. But this is the first time a drug has been scheduled that may not exist yet, but anything that has this particular effect on the cannabinoid receptor. So we'll talk about cannabinoid receptors when we talk about marijuana. But cannabinoid receptor type 1 agonists are, as we've just learned, drugs that affect or promote the functioning of those cannabinoid receptors. And so we'll talk more about this when we reach that discussion on marijuana. Schedule 2 is a drug that has a high potential for abuse, has a currently accepted medical use and treatment in the United States. The abuse of the drug or other substances may lead to severe psychological or physical dependence. So high potential for abuse, high potential for dependence. So these include drugs like cocaine, amphetamine, methylphenidate, oxycodone, and fentanyl. So high abuse potential and with currently restricted accepted medical use. Cocaine has uses as a topical anesthetic. In fact, it's often used in things like nasal surgery because it's one of the best topical anesthetics for that. Amphetamine and methylphenidate are used for treating attention deficit disorder, and then oxycodone and fentanyl are both pain relievers. So these are drugs with a significant amount of potential for abuse. Schedule 3 has potential for abuse, but is less than the drugs in Schedules 1 and 2. It has a currently accepted medical use in treatment in the United States, and abuse of the drug may lead to moderate or low physical dependence or high psychological dependence. And we'll talk about physical and psychological dependence at a variety of points in the semester. But examples of this schedule include combination drugs with hydrocodone with less than 15 milligrams per dose. So things like Vicodin that have a pretty high hydrocodone dose. Other drugs in this schedule include ketamine and anabolic steroids. So Vicodin, ketamine, anabolic steroids, or any drug that has hydrocodone with less than 15 milligrams per dose. More than 15 milligrams, it goes into Schedule 2. Schedule 4, low potential for abuse relative to drugs or other substances in Schedule 3. Currently accepted medical use. Abuse of the drug or other substance may lead to limited physical dependence or psychological dependence relative to the drugs or other substances in Schedule 3. Examples here include alprazolam, which is Xanax, Valium, which is diazepam, lorazepam, which is Ativan, and modafinil, which is a new drug supposed to treat narcolepsy, but is being used as a cognitive enhancer by some people, and we're going to visit that issue later on. So these are drugs that have some potential for abuse. We'll talk about alprazolam and its potential for physical dependence, because there is a pretty significant risk of physical dependence with Xanax in people who take it every day. Perfectly safe to use on occasion, but daily use can lead to physical dependence, and we'll revisit that when we get to benzodiazepines. Finally, we have Schedule 5, low potential for abuse relative to other drugs. In Schedule 4, has currently accepted medical use. may lead to limited physical dependence or psychological dependence. And these are primarily things like codeine-containing cough syrups. So that seems to be primarily what ends up in Schedule 5. And there is potential for abuse, but not nearly as much as, say, oxycodone or hydrocodone in a pill form like a Vicodin. So those are the 5 schedules. The last thing I want to talk about under the Controlled Substances Act is scheduling, descheduling, and rescheduling. So there are a variety of determinative factors that control or remove removal from schedules. So this is under the United States Code. In making any finding, the Attorney General has to consider the following factors with respect to each drug or other substance to be controlled or removed from the schedule: its actual or relative potential for abuse, scientific evidence of its pharmacological effect, the state of current scientific knowledge regarding the drug or other substance, its history and current pattern of abuse, the scope, duration, and significance of abuse, what, if any, risk there is to the public health, its psychic or physiological dependence, liability, and whether the substance is an immediate precursor of a substance that is already controlled under this subchapter. So these are all things that the Attorney General is supposed to consider when making a determination about where to schedule a drug under the Controlled Substances Act. The Drug Enforcement Agency is currently looking at rescheduling cannabis to Schedule 2 or 3. We will take a look at this. It's entirely possible this may happen sometime this summer. So we're going to keep an eye on that throughout this term and see where things are with this particular issue. So the next thing I want to talk about is the prevalence and incidence and impact of drugs of use and abuse. We're going to talk quite a bit this semester about the Diagnostic and Statistical Manual of Mental Disorders, which is called the DSM-5. The DSM is developed by the American Psychiatric Association as a way to diagnose a variety of mental disorders. For the time being, we're interested in looking at substance abuse disorders, which is a specific diagnosis under the DSM, and this can be mild, moderate, or severe. And really, the difference is how much impact a substance use is having on an individual's life. Is it disrupting their work? Are they unable to hold down a relationship? Have they lost their home? Are they completely dependent on a drug? All those go into this variety of diagnostic categories. And you can take a look at that by looking at the DSM online, and I will post a link to that as well. So when we talk about incidence and prevalence, it's important to understand the difference. Incidence refers to the number of new cases in a period of time. So a higher incidence means an increasing rate of cases. So we're going to talk about the increased incidence of opioid addiction and opioid overdose later on in the semester. Prevalence simply refers to the total number of cases of a particular disorder or disease. So how widespread is the problem? So increasing incidence obviously leads to increasing prevalence. So they're tied together, but they're different. So both the incidence and prevalence of drugs of abuse are on the rise for some types of drugs, but not all. We can talk a little bit about how these things tend to come and go, sort of almost like some drugs become fashionable or go out of favor or get cracked down on more, but drugs kind of come and go in their popularity. The other issue that we know is that during high times of stress, or economic stress in particular, is when drug use and abuse tends to go up. And so obviously we're just coming out of a long recession period, or still trying to get out of a recession period, and so there is still some major issues with substance abuse, particularly in economic depressed areas in the United States. So if we take a look at different drugs that we will talk about this semester, the overall prevalence of drug use for all drugs has gone up, so the incidence has increased, so we're getting more new cases. This drug shows the prevalence, but you can see as the graph goes up, that means the incidence is also going up. Marijuana is the most commonly used illicit drug. Prescription drugs are the next most commonly used, followed by cocaine and then hallucinogens. So marijuana is the most common, but still we're talking about less than 7% of the population. Less than 10% of the population uses any illicit drug at all. So pretty low overall rate. And only about 1% of the population reports using cocaine. Important to keep in mind whenever we talk about these kinds of studies, we're talking about self-report. So these are self-reported cases of using these drugs in the past month. So in all probability, it's higher than what's shown here, but probably not by a great deal. And obviously that's something you just simply can't know. So if we look at age range, this is where things start to get interesting. Drug use is the highest amongst people in their late teens and early 20s. It's no surprise. It's when people are experimenting, trying to find themselves, when they're in college, drugs are more available, lots of people doing them. So it's really not surprising at all. But drug use is really increasing. This is where we're getting the highest increase in incidences amongst people in their 50s. So you can see from about 2008 on, actually from 2002 on, we've had a steadily rising incidence in drug use, particularly for those over 50 to 54. You can see is the highest rate of drug use per month. This is particularly troubling is the increase in incidence of overdose. And again, this seems to be primarily driven by white men and women, in particular white women in their 50s and 60s. So there is a really significant increase in overall drug overdose deaths, particularly those involving opioids, as increasing over the last 10 years. So it's a really substantial problem that we'll spend a great deal of time talking about. One particular problem with this increase in drug overdose is the reduction in the life expectancy for whites in the United States. For the first time in a generation, or in some time, a group of people in the United States, a minority or an ethnic group, has shown a reduction in life expectancy. Everyone else, throughout most of the 20th century and 21st century, everyone was making gains in terms of life expectancy. Now, whites have always lived the longest, and that's obviously troubling. But at this point, white women in particular are having reduced life expectancy. Now, I think it's important to think about why we are focusing on that particular group when overdose deaths have been a problem in all other groups for decades. So that's an important conversation to have. But the point at this point is people are dying due to overdoses of opioids, regardless of who they are. We should certainly be thinking about how to solve that particular problem. So if you look at this increase in overdose deaths, if you look at deaths per 100,000, most everything else has been kind of on the downfall. Lung cancer deaths are down. Diabetes is slightly on the rise. But if you look at chronic liver disease, suicides, and accidental overdose due to drug and alcohol poisonings, really dramatic increases from 2000 to 2015. And so trying to figure out what's going on there is a really important thing to do, because chronic liver disease is likely due primarily to alcohol abuse. Suicides obviously is an underlying psychopathology, usually with depression, and probably that is underlying some of the alcohol abuse and drug overdoses as well. So it's something we'll have to revisit when we talk about opioids. For now, I want to turn and talk about the neurobiology of addiction and the reward pathway. So the reward pathway is an important part of understanding our motivational systems, what makes us feel like we have done something good, what is rewarding to us, and our sense of pleasure. And the first thing we'll talk about is the critical role of dopamine in this process, or this pathway. Dopamine plays a critical role in any feeling of pleasure that we have that comes from things like drugs abuse and abuse. We'll talk about a little bit of an overview of the reward pathways and then talk about the functional neuroanatomy of this reward system. So the major system, or the reward system, is one of the major dopamine pathways in the brain. We talked about the mesolimbic and mesocortical pathways. Previously we introduced dopamine, and that's really where the reward system is focused, is in this mesolimbic and mesocortical pathways. This is often referred to as the dopamine reward system. It involves important parts of the brain like the nucleus accumbens, frontal cortex, and the ventral tegmental area. So these circuits that are formed by dopaminergic neurons form what we call the reward system. The reward properties of all drugs are tied in some way to dopamine. Now, not all drugs are dopamine agonists, but they all have some sort of influence on dopamine transporters or dopamine release. So alcohol has its effect on dopamine, has a rewarding effect on dopamine. Amphetamines do have a direct effect on dopamine. But also, opioids have a rewarding part of their function through the release of dopamine as well. So dopamine increases in response to rewards. So something like cocaine is taken, dopamine increases are exaggerated, and communication is altered. So this reward pathway can get completely altered by drugs of abuse. So the reward properties of drugs that are tied to dopamine are things like direct increase in synaptic dopamine levels, like nicotine, cocaine, and amphetamine, or other drugs that indirectly increase dopamine by inhibition of GABA on dopamine neurons. So this includes the opiates and alcohol. So all of them are tied to dopamine in some way. Some are direct agonists, some are indirect agonists by inhibition of GABA on dopamine neurons. For a quick overview of the reward pathway, there are three major things that we're going to discuss: the hypothalamus, the mesolimbic pathway, and the mesocortical pathway. The reward pathways start in subcortical structures like the amygdala, the ventral tegmental area, and the hippocampus, and the circuit goes up then and ends up in the nucleus accumbens and the prefrontal cortex. So the hypothalamus is critical for all of our motivated behaviors, such as eating, drinking, regulation of our body's internal environment like our temperature, and also our sexual motivation. The hypothalamus is primarily directed towards consumatory behaviors, not goal-directed behaviors, but consumatory behaviors. So basically motivation to get out, eat, drink, have sex, get warm, get cold, that sort of thing. One of the properties of the hypothalamus that's important is the hypothalamic pituitary adrenal axis, which we call the HPA axis. This occurs during times of stress, and this can trigger a need for reward. So activation of the HPA axis, which is part of our stress response, the hypothalamus and the pituitary cause a substantial increase in the release of stress hormones like adrenaline and norepinephrine. As a result of that release of those adrenal steroids, we get an alteration in our need for reward. And so high stress can trigger a need for high reward. And that's going to be directly related to some of the issues we'll talk about in the effects of stress on the potential for addictive behaviors. So a quick overview of this mesolimbic dopamine pathway is the first one we'll talk about. Starts there at the ventral tegmental area and works its way up through the nucleus accumbens to the prefrontal cortex. So it starts at the VTA, the ventral tegmental area, goes to what's called the median forebrain bundle, the nucleus accumbens, and the limbic system. The limbic system is an important part of this process because it's regulation of our emotions and our memories as well. So the ventral tegmental area is the midline floor of the midbrain, receives its input from the subcortical attention system. So there's a subcortical attention system that directs our level of awareness or alertness, and so the ventral tegmental area receives some input from that attention system. The nucleus, or the median forebrain bundle, is a bundle of dopaminergic neurons which connects the ventral tegmental area to the nucleus accumbens and the limbic system. So it's just a simple bundle of neurons that connects these parts of the pathway. The nucleus accumbens is part of the ventral striatum. This part of the brain is particularly important because all of our feeling of reward occurs from activation of the nucleus accumbens. So whenever we feel good about something that's rewarding, the nucleus accumbens has been activated. Finally, the limbic system, the medial forebrain bundle projects to what's called the olfactory tubercle innervating the septum, amygdala, and hippocampus. These are all areas that are involved in emotion and memory. The olfactory tubercle is involved in our sense of smell. It's a reason why sense of smell can be highly tied to reward as well. So the limbic system is highly involved in this pathway, and in fact we'll talk at various times about how memory might play a role in addictive processes, because we remember those incidences of drug use as being positive and sometimes have better memories for those episodes. The mesocortical pathway is what ends up at the frontal lobes. So it starts at the ventral tegmental area and then goes through the prefrontal areas, the cingulate and the parietal cortex, which are involved in a variety of our reward-motivated behaviors. And so we're going to talk a little bit about how this system all works together to create our reward system. But that mesocortical pathway ends up at the cortex, and so one of the things we'll talk about is how frontal lobe functioning can influence our propensity for addiction. The people with lower frontal lobe functioning, lower working memory abilities, oftentimes are at greater risk for addictive process or for addiction. I want to finish this discussion of the reward pathway by talking more about the functional anatomy of the reward pathways. So talking about how these things are all connected doesn't get us very far because it doesn't tell us how they all work. So we're going to talk about what's called the reward prediction error signal, incentive salience, reward euphoria, and then anticipation of rewards and habit formation, which is obviously very important in our discussion of drugs. So the reward prediction error signal, initially dopamine neurons in the ventral tegmental area respond to the presence of a reward. If a sensory cue predicts a reward, those dopamine neurons fire in response to the cue, not the reward. So if you remember back to introductory psychology, you learned about classical conditioning, where you present a signal and that causes some sort of response, and then those two things get tied together. So for example, Pavlov's dogs learned to salivate in response to the ringing of a bell. Well, that's essentially what's happening here. This is more closely associated with operant conditioning, where we learn how to predict rewards in our environment. So if a sensory cue predicts a reward, those dopaminergic neurons will fire in response to the cue, not the reward. And this is how we can develop things like secondary reinforcers. So if any of you are familiar with clicker training with dogs, you essentially cue this clicker with treats, and eventually the clicker takes on the same rewarding properties as the treat does. That's what's happening, is this reward prediction error signal. If the reward fails to occur often enough, those dopamine neurons will decrease in firing. So you still have to occasionally pair the reward with the sensory cues. Important to understand that unexpected rewards will result in much higher dopamine releases and greater learning. So when we get a reward but aren't expecting it, we get a much larger neural response. This is one of the reasons why we get significant differences in learning based on the schedule of reinforcement. And so what that basically means is when a reward is unpredictable, it's essentially more rewarding to us because we weren't exactly expecting it. And so that's an important thing to understand about how our reward system works. So this is how we start to associate cues with different kinds of rewards. And we're just like every other animal. We start to learn how cues in our environment might be associated with reward and how our behavior is associated with whether or not we get that reward. Incentive salience is accomplished by the Mesolimbic pathway, which enhances the motivational properties of cues that are predictive of rewards. Those cues create more motivational, or get us more motivated because of this incentive salience. So the Mesolimbic pathway enhances the motivational properties of those cues. So those cues come up and we're much more motivated to engage in a behavior because we know it's predictive of a reward. That motivation is associated with the part of the brain called the amygdala, which is responsible for sort of our primal emotions. And again, this property is referred to as incentive salience because those cues become more salient and we're more incentivized to go out and find and engage in behaviors that result in reward. So our motivational states increase the incentive salience of reward and related cues. So if we're in a highly related, a high stress situation in a highly motivated state, those reward and related cues become more salient, they become more incentivized, and so anytime we're under a high stress situation, we're much more likely to go out and seek out those cues in their reward. So the next part of the reward pathway that's of particular importance for drug use is what's called reward euphoria. And this is where the high comes from drugs like cocaine, amphetamines. This is entirely the result of activation of the nucleus accumbens. Most research in this area involves cocaine and amphetamines because both cause substantial increases in synaptic dopamine. So it's a reliable way to look at how the nucleus accumbens causes this kind of reward feeling. In animal models, they will oftentimes directly stimulate the nucleus accumbens with a little current, an electrical current that will cause those neurons to fire, which is just as rewarding. If you block dopamine neurons in the nucleus accumbens, you get decreases in the reinforcing effects of dopamine in animal models. So in animals, you can actually put in dopamine blockades, and as a result, you get no reinforcement of drugs like cocaine and amphetamines because they get no reward at all from that kind of drug. Final issue to consider under the functional anatomy of the reward pathway is what happens when we start to anticipate rewards and how that results in habit formation. There are reciprocal connections from the prefrontal cortex and the hippocampus that drive anticipation and craving. The hippocampus is the part of the brain that's responsible for forming all of our long-term memories. And so these connections between the hippocampus and the prefrontal cortex are the things that tell us, oh, remember, you had that before and you want it again. And so that starts to drive this kind of anticipation and craving. And here's what's really important as we start to understand how environmental events can increase the risk for someone to develop an addiction. Reductions in executive functions, which are accomplished by the frontal lobe and are reduced in times of high stress, and are reduced in people with brain damage, particularly mild traumatic brain injury. These reductions in executive functions can contribute to the incentive salience of drugs and artificial rewards over natural rewards. So in these people who have reduced executive functioning, these artificial rewards are more salient to them than our natural rewards. And so the critical importance here is understanding how this happens, how those reductions in executive functioning can then result in an increased risk for addiction. It's one of the reasons why not everyone has the same addiction risk. And it's one of the things we're going to talk about throughout the semester is there is differential levels of risk for addiction depending on your circumstances, your genetics, etc. Not everyone carries the same risk of addiction, which is why some people can try cocaine once and be hooked on it and end up selling all of their furniture and end up homeless, and someone else can be what we call a weekend warrior, try it on Friday, be fine all week, a couple weeks go by, and then they'll party again. But understanding those differences and understanding there is a risk for there is always the risk that someone can become addicted is really important to being a smart consumer in these areas. So these reciprocal connections that come back from the frontal lobe and from the medial prefrontal cortex and the hippocampus, all of these, and back to the amygdala, all of these connections are part of this development of anticipation and craving. So this leads us to this questions of vulnerability to addiction. Stress certainly has some influences on our vulnerability to addiction. People who are under high amounts of stress, chronic stress, much more vulnerable to addiction. Our social context is really important. People who don't have a good social support system or a social support network are much more likely to develop addiction. Interestingly, in the animal research on addiction to cocaine, Animals were always kept, particularly rats, almost always rats, were kept by themselves, which is really stressful for rats because rats are social. They usually live in colonies. And they've discovered that if you put a rat that's been using cocaine by itself a lot and you put it in with a bunch of other rats, it goes back and uses the cocaine now and then, but not nearly as much so as when they were all by themselves. So there's an important social context. Genetics is really important. We're going to talk about epigenetics here in a bit, but not everyone has the same genetic predisposition for addiction. So that's how we get to this question of from abuse to an addiction. Repeated drug use can develop into chronic drug use that can become a compulsion and then result in an addiction. So people develop a compulsion to use drugs, and sometimes a compulsion to use drugs in response to stress, things that are going wrong in their lives. They use it as a coping mechanism. The frontal lobe, which is the part of the brain that really controls our attention and our ability to inhibit impulses, is profoundly altered by chronic drug abuse. You get what's called cortical hypofrontality, which means that frontal lobe has shrunk, and it's gotten smaller. So we get reductions in the size of the frontal lobe. This occurs after long-term drug use, and you eventually end up with fewer dopamine receptors in the nucleus accumbens than a normal person, and a lower metabolic rate in the frontal lobe, meaning the frontal lobes are functioning at a lower rate, and as a result cannot enforce that reason and inhibit impulses, and so people get impulse control and so are much more likely to use drugs. And because of those reductions in dopamine receptors in the nucleus accumbens, they require higher and higher doses in order to get the same effect. So if you look at the dopamine receptor availability in a non-drug user versus someone who has used cocaine, and this is heavy use over long periods of time, you get pretty significant reductions in frontal lobe uptake of, this is probably glucose in this PET scan. So as a result of chronic drug use, natural rewards become less pleasurable and release less dopamine despite greater response in dopaminergic transmission than normal. The frontal cortex becomes inherently less active and less responsive to normal rewards, but it's overactive in response to drugs or the stimuli that predict drugs. Memories of positive effects of drugs provide the motivation for compulsive use and is believed to be responsible for relapse. This is that circuit that's these reciprocal circuits that are coming back from the hippocampus, so it's mediated by the amygdala and hippocampus. Over time, stimuli that predict drugs produce a greater response in the reward pathway than the rewarding stimuli themselves. Such conditioned to learn responses can elicit powerful craving sensations in the frontal lobe, and the frontal lobes become sensitized to drug-related stimuli. So overall, this is a learned process that can become addictive over time. So where does craving come from? Well, this is where glutamate starts to play a role. This is a substrate of addiction. Hypersensitivity of the frontal cortex to drugs or drug cues, again, which is a result from learning, develops an addiction is the basis of the phenomenon of craving. And again, not everyone develops cravings, but people do crave drugs, and this is where addiction really gets quite strong. When they crave, they need the drugs. So craving is biologically mediated as increased glutamatergic reactivity within the reward circuit. So this increased glutamatergic reactivity within the reward circuit results in those cravings. Chronic use of drugs can produce common biochemical changes across drugs. So this delta phos-B is a protein that accumulates in the nucleus accumbens after chronic cocaine, amphetamine, opiate, alcohol, nicotine, cannabinoids, and PCP. So this protein accumulates in the nucleus accumbens after chronic use of these drugs. It also accumulates after chronic natural rewards. And this contributes to the sensitization, that is, increases in behavioral response to cocaine, opiates, as well as sucrose in consumption. So you're more sensitive to the presence of those rewards, so you're more sensitive and are more likely to pick up on them. The induction of delta phos-B mediates common aspects of drug and natural addictions by regulating a set of common target genes. So here's where we start to get down much deeper into how drug use starts to regulate genetic expression through the induction of this delta phos-B. So this is an important protein, and trying to understand its role is particularly important for understanding drug abuse. Final point on development of craving is some drugs of abuse also reduce neurogenesis. And neurogenesis is the development of new neurons, particularly in the hippocampus, that are responsible for maintaining brain functioning, for maintaining mood, and all disruption of neurogenesis is implicated in a variety of difficulties like depression. Disruptions in neurogenesis may be part of what happens with traumatic brain injury. So this is a really important thing to watch out for in the future. So how do our genes relate to the potential for addiction? Well, this is where we have to introduce some far more technical terms than we might have if we're really getting down into the technical terms. Epigenetics refers to how our experiences, our life experiences, alter genetic expression. So you may be born with a set of genes, but they get turned on and turned off, and then your experiences interact with your genes. It's how your genes and environment interact, and we call this epigenetics. So there are studies that suggest the heritability of addiction is moderate to high. So current research into addiction and other psychiatric disorders has greatly expanded to include the study of the relationship between environment and genetics. So your DNA sequence is an important part of the picture, but it's only part of it. Understanding your life experiences and how it interacts with your genetics is an important part of this. There are some structures of the genome that we're going to need to talk about, and this is going to become important again later in the semester when we talk about pharmacogenetics and pharmacogenomics. Chromatin are histones in DNA together. Histones are spools of protein around which strands of DNA are wound, and then the nucleosome are 8 histones plus about 160 base pairs of DNA. So, introduction to some basic terminology on genetics. I'm not an expert in genetics, so this is an area where we're all going to learn stuff together. But here's a little bit about how this epigenetic process works. You get modification of those histones. So epigenetic factors are biochemical molecules that bind to histone tails. When attached to histone tails, epigenetic factors affect how tightly a DNA molecule is wound around histones. DNA that is wound very tightly is not easily activated. DNA that is more loosely wound is more easily activated. So one of the things that happens in long-term drug use is an alteration in these histones. And so it makes it more likely that you get some sort of epigenetic alteration. So mechanisms that affect this process are aging, just general development, our diet, drugs or pharmaceuticals that we might take, and environmental chemicals. And the different health outcomes that result because of these epigenetic processes are things like cancer, diabetes, possibly depression, stress, schizophrenia even, etc. So the biochemical mechanisms of epigenetic processes include methylation, acetylation, phosphorylation, ubiquitination, and simylation. All of these are different ways in which these genetic codes get altered. So how does this work under normal conditions? When histones are tightly compacted, genes on the DNA are hidden within the nucleosome and are not exposed. So these can't be activated and turned on or turned off. So to turn genes on, which causes them to read or express them, or off, or not read or silence them, the structure of the chromatin has to be altered in order for genes to be turned on or off. And that's really the heart of the epigenetic process, is this sort of turning genes on and off. And a variety of things can alter whether a gene is expressed or not. To give you a couple of examples outside of what we're talking about now. Human beings are not inherently designed to be able to process dairy past the time that we normally would. So, for example, some people obviously are lactose intolerant and can't process dairy. And what has happened is their genes have gone back to sort of the way they were before we domesticated cattle and goats. It was a couple thousand years ago, or I don't know, 10,000 years ago or whatever, however long ago it was, when we started domesticating cattle and goats, that we actually started keeping that gene expressed. So we, for most species, once they're weaned from their mothers, they no longer process dairy. That gene shuts off, and in human beings it just stays on. But in some people it shuts itself off, and that's how you become lactose intolerant. And so that genetic expression is an important part of how we're able to do things like process dairy. Well, to take this back into our area, our experience with drugs might affect other genes that then cause some things to happen or other things to happen. So you might develop a disorder, might develop some other issue. So this is all this epigenetic process. So the psychiatric implications of epigenetics have yet to be completely determined. Some diseases have clear epigenetic etiologies. Prader-Willi syndrome, Engelmann syndrome, and Rett syndrome are caused by interactions at the genetic level. There's clear implications in cancer research. We believe also in Alzheimer's disease and schizophrenia. Schizophrenia, there seems to be a clear epigenetic factor of some sort, and all of this is ongoing. So I'd love to tell you more about it, but this research is in its infancy, and so we're learning more and more about how this whole process works and its implications. So how does this relate to drug abuse? Well, multiple drugs of abuse produce changes in that histone acetylation in the brain. So this indicates that drug abuse may cause some sort of epigenetic changes. These include cocaine, alcohol, and cannabis. And so we're, again, very early in starting to understand this process, but it is something to keep in mind. And finally, stress may play a role in epigenetic changes. So we know long-term stress causes a variety of health outcomes, and some of that may be epigenetic in nature. So the last area to talk about today is some pharmacotherapies for substance use disorders and what we might be able to do to treat substance use disorders. So the first idea here is what's called an agonist substitution treatment model, where you prescribe a substitute drug for the abused agent. So it's basically you're replacing whatever drug they were addicted to with something different. So in opioid addiction, with heroin addiction, the drug used is methadone. And you've probably heard a lot about methadone clinics. There's lots of controversy around these. But the basic idea is someone goes on to methadone and is on it for about a year, and eventually they'll get past their withdrawal period. Methadone's not nearly as rewarding as heroin is, and as a result, eventually you can get people off of heroin. With nicotine addiction, this is really what we call a harm reduction approach. You're not replacing nicotine with anything other than just a different form of nicotine. So rather than smoking nicotine, you provide nicotine lozenges, gums, patches, now inhaled, vaporized forms of nicotine. We'll revisit this when we talk about nicotine. And then with alcohol addiction, disulfiram or antabuse is a way to discourage alcohol addiction. Antabuse actually makes people pretty sick if they abuse alcohol. The next approach is to do a partial agonist substitution treatment. Basic idea here is to not completely agonize, become an antagonist, not agonize, become an agonist for the neurotransmitter, but partially do so. And so in order to sort of lightly let someone out, get someone out of their addiction. So buprenorphine is a partial agonist for opiate addiction, shows some potential. Varenicline, which is an alpha-4 beta-2 partial nicotinic agonist, has been demonstrated to be really effective in nicotine addiction for some people, actually for most people. There is a genetic, a genotype that does not respond to varenicline, which is under the brand name of Chantix, but this is a really good way to try to get off nicotine. Dopamine partial agonists, in theory, should provide enough dopamine activation to reduce the effects of withdrawal, yet block the consequences of illicit substance stimulant use. So cocaine and amphetamines might benefit from a dopamine partial agonist. In fact, there are some drugs that have been showing some promise in this area, particularly modafinil. Another potential treatment for addiction is to use an antagonist. An antagonist directly block the reinforcing effects and eventually reduce the compulsive behavior by completely blocking the receptor subsite. So naloxone is an opioid antagonist, and we're going to talk about naloxone. It's also called Narcan because it's really important for reversing the effects of opioid overdose. If someone has overdosed on an opioid, immediate treatment with naloxone will reverse the effects instantly, and the person will live rather than overdose. The problem with these treatments, like naloxone and naltrexone, is there's no positive reinforcement because they're not getting the rewarding effects of the drug itself. So adherence is really difficult, and relapse is very likely. And in the case of naloxone, it's not going to help at all with the withdrawal effects of going off of opioids. Another target is non-dopaminergic neurotransmitter systems, so things like GABAergic systems. So GABA B agonists such as baclofen can reduce the reinforcing effects of several different classes of abused drugs. Other GABAergic medications are being tested as possible agents for preventing cocaine relapse and are also anticonvulsants. So if someone is a severe alcoholic, they'll go through seizures if they try to withdraw from alcohol on their own, and so oftentimes they'll be given a benzodiazepine sedative to treat that particular problem. New directions in this area: there are the potential for vaccines as a promising therapy for relapse prevention. These stimulate the production of drug-specific antibodies, so to nicotine, opiates, cocaine, or amphetamines. If the drug of abuse is used, the antibodies bind to the drug molecules in the blood and prevent them from crossing the blood-brain barrier, thereby blocking the euphoria produced in the brain and presumably decreasing further use because they simply become non-reinforcing. So that's our introduction to the epidemiology and neurobiology of addiction. We'll talk more about these issues as we continue on in our series.